Yeah, sounds good.
Okay, so welcome everyone. Good afternoon. My name is Annabelle. I'm the sales manager for DYN'R, and I'm also a clinical specialist. Today we have Felicia Greta with us. She's the technical manager at Cleveland Clinic, Florida, and she's going to present um, her presentation today. If you have any questions, you can write them in the chat and we will answer them in the end. And Felicia also has left her contact. So if you have any questions that you would like to ask her directly, you will see that at the end of the presentation. Felicia, the mic is yours.
Thank you. Thanks for the introduction, Annabelle. Good afternoon, everyone. So in our business of radiation oncology, every millimeter matters. So having tools that allow us to be more precise is very important. But just having those tools isn't enough. Training is a critical step, and having a good understanding of the how and why empowers us to create workflows that add quality to our treatments. One such tool that we have is SDX. And so today I want to do just a quick overview of why we use SDX, the equipment and its function, the challenges that we've encountered on our journey with SDX, and the outcomes that we've had. And then we'll wrap up with the case study that shows the difference in those outcomes between having trained therapists and less experienced therapists move through the process. Okay, so like we mentioned, precision is key. A breath can be the difference between hitting our target and risking healthy tissue. So with the respiratory motion management system, like SDX, we can take control of that breath and use that moment of stillness to deliver really accurate treatment. Also, since the target isn't moving, our physicians can draw tight margins, thus sparing healthy tissues and resulting in a better clinical outcome for the patients. For us here in Weston, we use SDX exclusively for SBRT treatments that require breath holds. So areas that are commonly treated are lungs, livers, pancreas, and abdomens and abdominal nodes. So we use SDX for our SBRT treatments because it measures the actual lung volume and it's a patient-controlled system. And so to do this, the SDX module uses a spirometer to measure the amount of air a patient inhales and exhales. So there's a few components. The first is a sensor that tracks the volume of air being inhaled and exhaled, a bacterial filter, a soft snorkel-like mouthpiece that allows the patient to breathe through their mouth, nose clips that prevent any nasal breathing, and video goggles so that the patient can see their breathing pattern in real time. So through the video glasses, the patient can see this gray screen in the bottom of the corner. They're able to see their breath as it rises and falls. And then the visual of the body is actually a really nice representation of how a tumor can move during normal breathing. So you'll see like that supine motion as the patient breathes. So once that patient achieves these 3 stable breaths in this bottom right corner, a green bar will appear that shows the patient their target depth to breathe into. And then as they hold, we can see that the tumor stops moving and the treatment can be delivered very accurately. So while this looks simple enough, if you observe enough patients or if you try this yourself, you'll find that breathing is actually pretty hard. And I think we can all agree that no matter what system we've used, there are inherent struggles when active patient participation is required. Now, our goal as therapists is to really have the patient lay still and be as uninvolved as possible. So adding this layer of patient participation adds a bit of frustration. And to be effective, there has to be a solid process in place for your therapist to be able to train the patients. Now, when we first began using SDX 10 years ago, we were met with a lot of challenges because we did not have a stable, sustainable process. We encountered challenges like high anxiety and overwhelm exhibited by the patients at the time of SIM specifically, which affected their performance. We lacked uniform standard language to give directions. So the patient might hear one therapist say, take a slow, steady breath and hold versus breathe in, which can affect the depth and quality of the breath the patient's taking, making it pretty inconsistent, which obviously then caused difficulty aligning, and then it resulted in longer treatment times. So we had that inconsistency and increased time on the table, which was very uncomfortable for the patients, and then an added layer of frustration for the therapist. So from our challenges, we identified 3 pain points: patient anxiety, reproducibility and alignment, and then these long treatment times. So our first step was to address patient anxiety. We surveyed our patients and we found that what was fueling their anxiety was uncertainty. So things like being unsure of what to expect during simulation and treatment, being unsure of how to breathe correctly, being scared of doing it wrong, being intimidated by the equipment. And so while our physicians and nurses are fantastic at explaining the process during consultation and the pre-SIM education appointment, we found that it was difficult to get a good understanding without having a visual. So many moons ago, we created a short video that the patient watches right before the SIM to help them feel better acquainted with the process. Welcome to Cleveland Clinic, Florida, Department of Radiation Oncology, where we pride ourselves in being leaders of innovative technology and techniques. Our goal is to deliver the highest quality and most comfortable patient care. Today, we'd like to acquaint you with some equipment you may encounter during your treatments. This video is a brief introduction to the SDX Respiratory Motion Management System.
I'm John Greskovich, the Chairman of Radiation Oncology at Cleveland Clinic, Florida. Today, I want to describe our SDX Respiratory Motion Management technique. Certain tumors in the body move with respiration, such as lung cancers, liver tumors, upper abdominal tumors, such as pancreatic cancer, and even breast cancers. We want to minimize that motion when we're targeting radiation, so we have patients use something called a deep breath hold technique. By having patients hold their breath, we can target more effectively and minimize the damage to the surrounding normal tissues.
This system is designed to let you be an active participant in your radiation treatment. First, let's begin with the simulation. During your simulation appointment, your radiation therapist will work with your physician to determine how to best position your body for treatment. Again, one of our main goals is your comfort. So if at any time you feel pain or are unable to maintain the position, please let your therapist know. You may need to hold this position for up to 20 to 30 minutes daily. Once a comfortable position is achieved, your therapist will explain and position the SDX equipment. A soft, rubber, snorkel-like mouthpiece will be placed in your mouth. Lightly bite the inner plastic tabs and create a tight seal with your lips around the outer portion. Then, a padded nose plug will be placed over your nose to ensure all airflow is occurring only through your mouth. Finally, a pair of video goggles will be placed over your eyes. These goggles will allow you to see a video screen showing your breathing pattern. Let's take a further look at the images on the screen. As you breathe, you'll notice a red line climbing and falling. The climbing portion represents your inspirations, and the falling line represents your exhalations. It is not important to be able to see any numbers or words. You'll want to focus on breathing as normal as possible. Allow your expirations to end within the gray line at the bottom of the screen. Once you have achieved 3 consistent breath cycles, your therapist will ask you to take a slow, steady, deep breath in. This breath does not need to be excessively deep. Instead, take a very comfortable breath that you can hold for about 15 to 20 seconds. Remember, This is based on your own unique ability and allows your physician to create a personalized treatment plan specifically for your ability. Your therapist will have you take a series of 3 deep breaths. A bar will appear on the screen. This green bar represents the level to which you are able to hold your breath. Now, your therapist will practice your deep breathing with you. Your therapist will coach you to take a slow, steady, deep breath into the middle of the green bar and hold. As you take a slow breath in, pay attention to the red line and hold your breath once you reach the middle of the green bar. You'll also notice that when you have gotten your breath into the green bar, an orange light will activate at the top of the screen. This indicates that you have successfully achieved the level of inspiration necessary for imaging and treatment. Don't worry if it seems a little tricky at first. This simulation is designed to get you comfortable with the equipment. We will explain the technique in practice until you feel fully comfortable moving forward. Once you and your therapist feel you can consistently take a deep breath into the middle of the green bar and hold it for about 20 seconds, the scan will begin. During the scan, hold still and listen for the verbal cues from your therapist and look for the visual cues on the screen. You will be asked to take a deep breath into the middle of the green bar. While you are holding your breath, the scan will be completed. This scan takes about 20 seconds. You will hear your therapist over the intercom say, "Breathe." At this point, you can release the breath hold and return to a normal breathing pattern. Remember, keep holding still. During this time, the physician will look at the scan and determine the area of treatment. Your most important job is to remain absolutely still. We hope this brief introduction to our SDX respiratory motion management system has helped you feel comfortable with the process ahead. Thank you. We look forward to being part of your world-class care. So for us, that educational video was critical in the patient training process. Not only did it introduce the patients to the system, but it really reduced their anxiety and they felt more comfortable with what to expect. It also created for our team standard language to be used. So for example, the phrase, "take a slow, steady breath in," or "take a breath into the middle of the green bar and hold." That consistency helped the patients just be more comfortable during the process. So the video was a great foundation for us to standardize our process. And then that brings us to our next challenge, which was reproducibility and alignment. So at the time of sim, during the patient training process, we're also assessing if the patient is an ideal candidate. Because if the patient's not a suitable candidate, they're going to struggle and they're going to have difficulty performing. And then we're going to have difficulty aligning. So we want to look for a few things. Our ideal candidate is someone that can hold their breath for about 20 to 25 seconds. They aren't in any severe pain. They're not extremely claustrophobic or anxious, and they're able to understand and follow directions given by the therapist. So once we've determined that a candidate is ideal, we move forward with the sim process. And while a lot of this is standard, there are a few steps that we find can really help reproducibility. So first, standard, immobilize the patient. Then we put in the patient's mouthpiece and the nose clips, but we do not give them the video glasses. We actually just position the patient and we ask them to lay there for a few moments while they get accustomed to how the mouthpiece feels. They get accustomed to breathing through their mouth. They're getting comfortable with the position that they're in, and they're not thinking about their breathing. At this point, we're not even mentioning their breathing because we don't want them to be actively thinking about it, which is another reason why we don't give them the video glasses. The phenomenon of self-conscious breathing is real. So people tend to alter their breathing if they know they're being observed. And if you haven't tried SDX yet, I encourage you to do it. It's actually pretty fun. I attempted it here. And in the video, you can see in the beginning, I was just really getting accustomed to how the mouthpiece felt. And it is tricky to breathe out through your mouth through the snorkel. And so once I was comfortable, I actually started watching myself breathe. And it was almost immediate and instinctual to just think like, oh, I could absolutely be breathing in more. And I started building these peaks that just was not my norm. So I tried again to just stop watching, and I was able to regulate a little bit better, but still not back to what my baseline was. And so when we first start a patient and we're trying to figure out what their regular breathing looks like, we want them to be as unaware as possible of their breathing pattern. So after we're regulated, we have the patient start creating their threshold. And to do this, we capture 3 stable breaths. We find an average of those breaths, and then we're going to close the gap to 0.5, and I'm going to explain what that means. Okay, so here's how that process looks of capturing those 3 stable breaths. So once the patient starts breathing, we think their breaths look regular. They're going to take 3 stable breaths in. We prompt the patient, take a slow, steady breath and hold. And they do that to the best of their ability to whatever level they're comfortable with. And then they exhale. And once they exhale, we capture that test phase. And so we repeat this 3 times to get a good view of their consistency and to make sure that they're able to do it and that they're not having outliers all over, that they're pretty consistent in where those breaths are landing. Ideally, what we're looking for is for these all to be at the same level. So these 2 are really nice because they are very similar in the depth and in the consistency. This young one is kind of an outlier. So when we choose our phases, we are going to choose something that's like kind of in the middle of where everything lands. And so in this bottom screen to the left, if you were to double click the phase that you want, it's going to create this separation. This separation is going to represent that green bar that the patient will breathe into later. Now, if we look at this separation, our default is 0.1. We think that's a little bit too thick, so we like to reduce this gap. So on the bottom right in this corner, you have a few options. There's an option for the gap plus or minus. It's generally set to 0.1. I don't know if that's a default for all systems, but it is for ours. So we reduce that to 0.05. And as we reduce it, you can see that it makes the bar, that space, thinner. We think this is important, and we find that it helps during treatment because if a patient has a thick bar and essentially a thick target to breathe into, they may breathe to the top portion of that bar on one breath and the bottom portion of the bar on the other. And while they're still within their range, it does create a little bit of motion. By making the bar thinner, we're essentially forcing the patient to be more targeted, more precise in that breath. And so we're able to see less motion on imaging and during treatment. So once we have chosen the area that we want, we're happy with that threshold, we're happy with where it's landing, we can adjust the level of the bar with the level option in the breath hold level box at the bottom right. And what our goal is to try to get our target breath, our target test phase, in the middle of that separation. So all of those improvements, they definitely helped alignment, which helped our sim times. And so that brings us to our final point of the time on the table. So we improved the times by keeping our SDX sims in a 2-hour time slot. Initially, we had a 1-hour sim time slot, but our treatments on the machine were taking up to an hour and a half. It was just not a sustainable process, especially with how many SBRTs with SDX we were treating and how busy our patient schedule was. So we tried a few different things out. We found that an hour time slot was really not enough time to adequately train a patient, especially if they needed more time, more practice. So we kept a 2-hour time slot to invest the time on the front end, you know, and save a significant amount of time on the fractions later. We were able to reduce our treatment times from an hour and a half to 45 minutes or less, often for multi-ISO centers. So that's 2 CBCTs and treating 2 areas, often with 2 to 3 ARCs, which is a big improvement. The patients are more comfortable and there's less frustration all around from therapists and patients. So there was a lot of collaboration that was put into the workflow, and it's quite an undertaking, but nothing is quite as rewarding as when you can see the difference that it's actually making. So we have an example of a patient that came in for simulation. It's a 70-year-old male with 3 oligomets in his right lung. He was scheduled to receive 5 treatments of SBRT with SDX, and he was a great candidate for it. He wasn't in any respiratory distress, he wasn't in any pain, and he was able to hold a great breath. So on the first day that he came in for simulation, we were unable to access the educational video because of the Dropbox link. The Dropbox link just wasn't working. So the patient didn't see the educational video before the simulation. And the RTs that performed the sim were newer, so they weren't as well versed with the process or language that we use. Now, at the time of sim, we do take 2 breath hold scans. For this reason, our goal is to overlay them just so we can see if there's consistency or not. And here we can note that there were significant inconsistencies. You can see that there's motion with the rib cage, the diaphragm position, the heart position, and the tumor position. So this would not be ideal for a good plan to be created. So we had this patient come back for another sim. On this day, the patient watched the video. They were taken through the sim process as we described earlier, and we did the 2 scans and we merged them. And you can see that they're nearly identical. So as a quick recap, training the RTs was critical and it really did make a difference. We found ways to reduce patient anxiety, to create a uniform standard language, to have a consistent sim process that improved our treatments over time. Thank you so much for listening and for attending, and I'm happy to answer any questions you may have. And here's my contact information. Feel free to email me as well.
Thank you, Felicia. That was a great presentation. We actually already have some requests about this presentation. So everyone, thank you for being here today. Please write your questions in the chat so we can answer them. We do have a question. Can you explain again the solution that allowed you to reduce treatment time from 1.5 hours to 45 minutes?
Yeah, so for us, the problem with the treatment times was that the patients were still struggling to understand the process and they weren't grasping how we needed them to breathe. So we added a little bit of extra time to the simulation day so that we could spend more time upfront training and ensuring that they were really well prepared to go into the treatments. That in itself was a huge help. And then also watching the video to just get them better acquainted. Really, the upfront training is what improved ultimately the treatment times in the end.
Okay. Somebody is asking if there is a charge for billing for the SDX, maybe a special procedure charge. How do you do it, Cleveland Clinic?
So we bill a respiratory motion management charge at the time of planning, and then the SDX is a complex charge during the simulation as a device.
And I'm sure if you want to have more details, you can also email Felicia directly to see how they're doing. Okay, another question is what percentage of patients are deemed unsuitable for breath hold?
Oh, good question. Okay, so we it's a little tricky because sometimes you need the physician on board as well to really agree that this is not going to work out, that we can maybe go to a compression route or something different. Often we really try to work with the patient to coach them. I would think about maybe 10% or less. I don't think it's a significant number that we can't. Our physicians are pretty reasonable in identifying which patients they think it's going to work for. So then we just try our best on the back end to make that work. But if it can't happen, it just can't happen.
So they do already like a very thorough screenage during the consult, and they're able to be reasonable in the type of patient that they send you.
Absolutely.
That's great. That's great. Another question here. In addition to the minimum breath hold time of 15 to 20 seconds that you're required to identify suitable candidates, is there also a minimum number of breath hold? For example, does the patient need to be able to do at least 3 breath hold or 15 to 20 seconds?
Yes, so that's good. At the time of SIM, this is also something that we've worked on. Instead of just doing those 3 test breaths, we actually have the patient do up to 15 because that really is more indicative of what will happen when the treatment happens. And we want them to be prepared for that process. So if they can make it through 1 or 2, great. But if they can't make it through 15, then they're really not ideal for the treatment. So at the time of SIM, again, in that 2-hour time frame, we're having them take up to 15 breaths and holding for 15 to 20 seconds.
Okay. All right. We're going to wait a few more minutes to see if there's more questions. Okay, so we have one more. Do the therapists at the time of setup have any specific language they use to reinforce the training from SIM day? And do you have a credentialing process for therapists to be involved in SDX?
So we try to just keep standard language of how their patients are taking the breath. So we like to say, take a slow, steady, deep breath because it's more mindful, and then they tend to fill their chest the same each time if they do it that way, as opposed to just take a deep breath where sometimes it's diaphragmatic breathing or thoracic breathing and it might alternate. So we try to keep that language standard. And then as far as credentialing, we do a like a competency with our newer therapists coming in. Sometimes, you know, it doesn't always work out perfectly, but we do try to make sure that everyone's completing a competency before they're independently doing the simulation.
And I know that there are a lot of sites that have one or two SDX reference, like a person that is really an expert and that will take care of the patient, like take care of the SDX patient mainly, or that will assist the therapists that are not yet expert with the SDX. I've seen that in a lot of different hospitals. We have another question here. Does anyone ever use SDX for standard breast treatments or only SBRTs?
So
I
for
can
us,
take that. Oh,
no, go
so
ahead.
yes. So yes, the SDX is used mainly for breast treatment in photon therapy. What's your experience, Felicia, at Cleveland Clinic?
So we began using SDX for our DIBH breast patients, but this was early on and we just did not have a solid process yet. The number of breast patients that we were doing was just too great. So for our breast now, we use a surface guided system, but the reason we're still using this for SBRT treatments is because measuring the actual lung volume is much more consistent and accurate than measuring just the chest rise that you would get with surface guided. So we are exclusively using it for our SBRT patients.
Okay. Everyone is still connected, so if you have any questions, feel free to write it in the chat and we'll be happy to answer it. And everyone, you should have seen a poll appearing on the screen. We want your opinion. We want your answers on a few questions. So if you have a minute, please answer the poll for us. We do have a question here. Can I see this recording later again? Yes, we have recorded this presentation and it will be on our YouTube channel probably by tomorrow. So you'll be able to see it again. Okay, we still have Felicia with us, so feel free to ask any questions. All right, I think we're done with the question today. Oh, actually, we have one more. Does Cleveland Clinic Florida also use SGRT for the SDX patients? I think it means, do you use it in, like, do you combine both?
Yes, we do combine both, but when we're treating our SBRT patients, our gold standard is the SDX. So as long as we are in our threshold, we deliver treatment. And 99% of the time, we are still within our SGRT as well. But we do monitor and track all patients.
Okay. Do you use SDX for both proton and photon?
We only have photon here at Weston. We're not fancy yet.
There's actually a lot of proton sites in Florida, so you know, maybe you'll get some. One more question. Have you looked at a difference chest breathing, abdomen breathing with the same lung volume? Did you get that?
Yes, yes.
Yeah, okay.
Yes, there is a little bit of a difference when a patient takes a diaphragmatic breath with like a belly breath versus a chest breath. But at the time of sim, we try to go with whatever's most natural for the patient and not force them into something that might feel unnatural for them because it will affect if they're consistent later. So while we're observing how they're breathing, whether it's chest or diaphragm, we just have them take that same breath with whatever they're comfortable with as long as it's consistent. Because really what we're looking for is motion management, not so much separation of the chest like we would for a breast patient. So in that case, just patient comfort is our goal.
Okay. Are you getting the beam automatically with SDX?
No, we manually control the beam.
But you do have the MMI, right?
We do
So
have the
it could be an option. Okay. So yes, the SDX can talk to any variant LINAC as long as they have the motion management interface that is open. I believe you have two systems, right? You do have one system that covers room and one system at the sim.
correct.
Are treatment times the same for liver, lung, and pancreas? That's a good question.
Generally, we can do them in 30 minutes to 45, depending on how the patient breathes as well. If they're able to hold their breath for longer, it makes the treatment faster. It just depends on a few variables, but the majority of them are about 30 to 45 minutes.
Yeah, I think that's pretty normal. That's a pretty regular time from what I've seen in different hospitals. If there's any other SDX users that are connected, feel free to send maybe the treatment times in your hospital to treat, liver, lung, pancreas, or even SBRTs. Feel free to share also your experience. We do have a question here. How many breath holds must a typical patient take for the entire treatment? Let's consider it's an SBRT treatment. That's a good
Okay,
question.
so for a CBCT, it takes 3 to 4, and then each arc, depending on the MUs, maybe the same, about maybe 3. So I would say about for a patient with 3 arcs and a cone beam, up to 12.
How long is your cone beam?
About
Like,
a minute. So about, if
okay.
considering 15 to 20-second intervals, depending on the patient, and then the delay of the cone beam starting. So a few
Yes.
factors.
Okay.
About
Got it. All right, everyone. Well, if there's no more questions, I think we're gonna let Felicia go back to the clinic today. Oh, one more. Do you have the same tolerance for all patients? I guess it's the threshold.
so the threshold, the height of the threshold, the depth that the patient's breathing into, that's set per patient based off of their ability and what they're comfortable taking a breath into. But for the actual gap that we're setting, we keep that consistent, and that's 0.05, just to make it very thin, to force the consistency in their breaths.
Okay. By how much do you reduce the breath hold level from the patient's maximum value achieved during SIM?
So sorry, and what do you mind repeating it?
Yes, you know how when you test the patient breath hold, then you reduce it by 15 to 25% to keep the patient comfortable. What is the average value for you? Is it 15? Is it 25?
So we don't reduce the percent of where they are. We actually just we choose a breath, like a test breath that is in the middle, like what looks like their average breath.
Okay.
And then we try to make sure that their test breaths are close to where that gap is. Um, but we don't try to reduce it because we're already coaching the patients to take a comfortable breath in, not to take an uncomfortable deep breath. So we found in the past that if we do reduce it too much or we reduce it um, incorrectly, that the patient will overachieve and then they'll go above the bar and we're not able to get them into the correct position. So we just go with an average of where their test breaths are. We choose a middle one. And then when we set our bar, we try to have those test breaths be somewhere within that area.
That's a very interesting approach. I think most of the hospital that I've been working with are actually using the percentage button in the SDX software. Um, so you're taking it reverse. You're asking the patient to stay comfortable so you don't have to decrease it yourself. Hmm, interesting. One more question. Is there any clearance issues with the SDX device with a small bore CT?
Oh, good question. So if the spirometer is straight up, it is quite high. And so there can be clearance issues with the CT and on the treatment machine. What we like to do is try to position the spirometer arm to either side of the patient and then kind of bend the mouthpiece forward. So the arm is not straight up, it's tilted to the side a bit. Or if it's a right or left lung, depending on where the tumor is, we'll have the patient turn their head a bit. But it is something to be conscious of, especially if the arm is directly above the patient.
Have you ever had to make an extension for the treatment couch to place the SDX on it? Like if, for example, if you're using a 5-point mask, like and it's it has the shape of the head. Did that ever happen?
So the only patients that we've used this for generally have an arm shuttle. And so it just sits really nicely at the top of the arm shuttle, on
Okay.
top of the arm bars would go. So we haven't had to add anything to the end of our couch.
Okay. Got it. Okay, we still have over 20 people that are connected, so I'm sure you have more questions. We still have Felicia with us for another maybe 10 minutes. Feel free to ask your questions here. Don't be shy. You also have her contact in case you would like to ask the question directly. Okay, we have one question for the arm shuttle. Do they grab the SDX handle like in the video?
Yes, we have our patients loop their hands under that silver bar on either side of the SDX. So
How
yeah,
do you? Mhm.
if we
Go
put
ahead.
the, we find that there's not enough, the module is not as stable on the arm shuttle. So we just use that extra space so that it has some stability when it's sitting. And then the patients can hold the actual SDX.
Okay. Um, how do you troubleshoot warm up and treatment if SDX is not functioning?
We call a physicist. We call Annabelle now.
Yeah, you
That's
call me. You can call me anytime. So we have a great technician, Carlos, and he's available pretty much 24/7. So you can always call the technician And Felicia's hospital is really close to our office in Florida. So actually she gets, VIP treatment.
Fortunately, we don't usually have a lot of issues. And if there is anything, it's usually something simple that's fixable over the phone. So we've been very fortunate.
And our technician is telling me to remind you all to put the SDX on. Don't forget to turn on the system before you call him saying it's not working, because that happens a lot.
Maybe.
Did it happen to you, Felicia?
Yes.
Okay, it did. So you see it happens even to the best of us. Okay, one more question here. Do you have any workflow in place to deal with situations where on treatment imaging shows that the internal anatomy does not match the planning CT well as the simulation breath hole level? What do you
Yeah.
do?
So we have two options. We generally we would probably rescan the patient and just try to coach them into some more consistent breaths to see if we get better results. And if the anatomy still is not aligning, then we just start from scratch. We would resim the patient and try to figure out why there's inconsistency. With the breath holds, like in the example, if the patient is coached well and they really understand the process, they can have a very consistent, repeatable, reproducible scan. So sometimes we can re-image and get that patient closer, but our goal is really to have that complete precision.
Mhm. I think it's also maybe a bit different for proton versus photon treatment. Um, I guess the tolerance regarding the anatomy versus the breath hole level.
Yeah. Our tolerance for shifts is 2 millimeters. So first we would align to bony and then we're looking at the soft tissue, but we are really also focused on just making sure all of the anatomy, the entire thing is very similar to what we're setting up. We wouldn't just, set up to the soft tissue and ignore where the bony tissue is landing as well. So looking for an overall good match.
Definitely. Okay, we still have 20 people connected, asking questions. And thank you all for answering the questions of the poll, especially about what the next webinar topic should be. It will definitely help us to schedule that later on. All right, Felicia, I think we're gonna stop here and let you go back to the clinic. Thank you again
Okay.
for being with us today.
No, thank you. Thanks, everyone.
Bye, everyone.